In this video, we are going to spend a few moments going over the basic structure and function of the respiratory system. In class, we will discuss the respiratory system in terms of the upper respiratory tract, the lower respiratory tract, specific disease processes such as asthma, COPD, tuberculosis, and then finally we'll go into respiratory failure, or the specific situation when a person is unable to exchange gases sufficiently to support survival. The goals of this video are to perform an overview of the respiratory system and to focus on the main function of the life-sustaining process of gas exchange. You should be familiar with the different anatomical landmarks as shown on this slide, such as the right midclavicular line or the right anterior axillary line, the midsternal line, and the different lobes of the lungs. The respiratory center of the brainstem controls respiratory function based on two main sources of information coming from the body. First, chemoreceptors from several locations give information about the acid-base balance of the blood and cerebrospinal fluid, or CSF. Chemoreceptors are located in the brainstem medulla and also in the carotid bodies at the bifurcation of the common carotid artery and the aortic bodies above and below the aortic arch. The respiratory center in the medulla adapts respiratory rate and depth, also known as tidal volume, to adjust to changes in the pH. In a normal, healthy person, this process is precise and effective. With some respiratory diseases, significant changes occur that we will discuss further in class. The other way that the respiratory center adapts respirations is based on mechanical receptors located in the lungs, airways, chest wall, and diaphragm. These mechanical sensors send information to the brain via the vagus nerve, which then adjusts respiratory effort, rate, and depth accordingly. You will need to review the upper and lower respiratory tracts, including the general structures found within each tract. Lewis provides a sufficient summary on pages 498 to 500. Please read that section. In general, we will call the nose, mouth to the trachea the upper respiratory tract, and the carina to the alveoli the lower respiratory tract. Know the turbinates, the epiglottis, the larynx, the carina, and the terms bronchoconstriction, bronchodilation, tidal volume, anatomical dead space, alveoli, the pores of Kohn, and surfactant. Respiratory anatomy includes several physical structures in the chest other than the lungs and airways. There are 24 ribs that support the chest wall and protect the lungs and heart from trauma. Intercostal spaces between the ribs contain muscles that expand and contract the chest. Also not shown on this slide are the scalene muscles, which are up here in the neck, which you sometimes see used with heavy work of breathing. Inside the chest cavity lie membranes called pleura. The parietal pleura line the chest wall itself. The visceral pleura lines the lungs. Between these two membranes lies a thin fluid-filled space called the intrapleural space. This fluid lubricates and connects the two pleural layers to facilitate lung expansion. Normally, pleural fluid drains into the lymph system. You may have encountered the term pleural effusion during your student career. I get asked frequently how pleural effusion and pneumonia are different. Pleural effusion involves a collection of fluid in the pleural space outside of the lungs. It is more painful than pneumonia because the parietal pleura have pain receptors that communicate the sensation of pain to the brain. Pneumonia is a collection of fluid inside the lungs, in the alveolar areas and the airways. The main sensation for that is shortness of breath or a heaviness in breathing. Now don't forget about the diaphragm. This is a very important respiratory muscle innervated by the phrenic nerves. As we learn in the neuro section, injury above the C3 vertebrae causes complete paralysis of the diaphragm, whereas injury to the C3 to C5 area can cause life-threatening alterations in respiratory muscle abilities. Let's review blood flow to and through the lungs. We have two different kinds of oxygen circulating to the lungs. First, we have the pulmonary circulation, which is shown in the diagram that's labeled pulmonary circuit. And then we also have bronchial circulation, which is the picture on the right. First, let's talk about pulmonary circulation. This is the circulation that supports the systemic body, where blood is pumped to the right side of the heart. You see there it's pictured as blue because it's deoxygenated, returning from the body, and gets pumped out into the pulmonary circulation, where it becomes oxygenated at the alveolar capillary membrane, and then the red blood, which is shown there by two red pulmonary veins, returns to the heart, to the left side of the heart, and is then pumped out to the body. This circulation also provides the alveoli with the blood needed for metabolism. Other lung structures are perfused by the bronchial arteries, which come off of the thoracic aorta, and that's shown in the picture on the right. You can see the aortic arches here, and here we have the bronchial arteries coming off. We have right side and we have left side. The bronchial arteries supply the bronchi and the parenchyma of the lungs, and they also provide some of the blood flow to the esophagus. Sometimes a picture is worth 1,000 words. Here's a pulmonary artery coming from the heart and going to the capillary level where it's oxygenated and returns by the pulmonary vein to the left side of the heart. Here's the bronchial circulation that comes off the aorta and supports the bronchi and connective tissue in the lungs. Now let's look more closely into the physiology of respiration. We're going to begin with ventilation, which includes both inhalation and exhalation. Inhalation is an active process that occurs due to decreased intrathoracic pressure caused by movement of the diaphragm and intercostal and scalene muscles. By making the intrathoracic cavity larger, pressure is lowered and air moves from the atmosphere through the airways into the lungs. Exhalation is passive because the chest muscles relax, increasing intrathoracic pressure and causing air to move out of the lungs. Chest and shoulder muscles can assist either inspiration or exhalation when needed. This is called accessory muscle use. Compliance is the measure of the ease of expansion of the lungs. There are several things to know about compliance. First, surfactant decreases surface tension, and that increases compliance. Fluid in the lungs will decrease compliance. Compliance is an important aspect of lung function. It refers to how much the lungs are able to expand or contract with respiration. There is an optimal range of compliance, below which there is decreased compliance, for example with the fluid in the lungs, and above which there is increased compliance, for example due to destruction of alveolar integrity. In other words, compliance is not a simple linear arrangement, from less being bad to more being good. There is an optimal compliance range where the lungs expand and recoil best, allowing for normal tidal volumes in gas diffusion areas. The muscles also participate in compliance. For example, the elastic recoil of the chest wall is dependent on an ability of the muscles to increase and decrease the size of the chest cavity. Atelectasis is a collapsed alveoli. You can see in this upper picture how nice and large the alveoli are, allowing for lots of surface areas for blood to meet the alveolar space. So this is an example of what one of the alveolar capillary membrane areas looks like in a regular alveoli. And you can see in the lower picture that there's not going to be as much surface area for the gases to diffuse across the membranes. You may have seen the term atelectasis when caring for your patients, and especially in postoperative patients. The alveoli may become collapsed because airways are filled with fluid or because of a lack of surfactant. The reason that deep breathing helps to prevent or resolve atelectasis is that deep breaths cause the pores of Kohn to open, and that allows for air to flow between alveoli in a collateral way, opening up the alveoli sacs. You can find a review of atelectasis on page 370 in Lewis. We frequently speak of ventilation and perfusion when discussing oxygenation. Ventilation can also be called external respiration because it connects our respiratory system with the external environment. We inhale oxygen and exhale carbon dioxide. Perfusion is also sometimes referred to as internal respiration because it is a diffusion of the gases at the cellular level that supports tissues inside of our bodies. Diffusion is the exchange of oxygen and carbon dioxide across the alveolar capillary membrane. In general, gases move from areas with higher concentrations to areas of lower concentrations. This is the basic process by which we sustain life. Oxygen moves from the atmosphere through the lungs and bloodstream to our cells, where aerobic respiration occurs. Meanwhile, carbon dioxide, which is a waste product of cellular metabolism, moves out of the cell into the bloodstream, where it is transported to the lungs and diffuses across the alveolar capillary membrane and is exhaled out into the atmosphere. This slide identifies the approximate partial pressures of oxygen and CO2 in a normal person at the alveolar capillary membrane. Please be sure that you understand diffusion in the lungs and at the cellular level. Also remember that the terms artery and vein in the lungs refer to differently oxygenated vessels than those of the rest of the body. In the lungs, the pulmonary artery carries deoxygenated blood pumped from the right side of the heart to the lung bed, and the pulmonary veins carry oxygenated blood to the left side of the heart from the lungs. Partial pressure of a gas is the pressure of an individual component in a substance that has a mixture of gases. For example, blood has multiple types of gases mixed into it, and each exerts a pressure known as its partial pressure. That's the full extent to which you need to understand partial pressure, but please remember the partial pressures of oxygen and carbon dioxide at the alveolar and capillary membrane. Here is a YouTube video which explains in more detail the process of diffusion. This is the picture that explains it to me. Here is the capillary, and here is the basement membrane of the capillary, and the interstitial layer between the capillary and the alveoli. And here's the basement membrane of the alveoli, and here's the alveoli. And that's how thin that layer is. And across these layers, the oxygen diffuses into the blood, and the CO2 diffuse into the lungs. Let's move on to the ways that we monitor oxygenation in our blood. We will delve further into these areas in class, but here are some basic terms related to oxygen monitoring. The SaO2 is also referred to as pulse oximetry. It's obtained using a sensor placed on the finger or earlobe, which sends across the finger a light to the detector. This method identifies the percent of hemoglobin that is saturated with oxygen, and under normal circumstances, it'll give us a pretty good idea of the patient's oxygenation status. But we also have to know their hemoglobin levels because it's only measuring the percent of hemoglobin that's saturated. So, for example, a person could have a 100% pulse ox, but if they have a low hemoglobin level, then they still might not be perfusing adequately. The SvO2 is a mixed arterial venous sample of blood, which we use to monitor patient status and changes in their status. We especially use this method of monitoring in the critically ill. The PaO2 is the partial pressure of oxygen that is dissolved in arterial blood. The PaO2 is an accurate measure of a patient's oxygenation status, but obtaining it is an invasive test that is only ordered when there is true concern about the patient's oxygenation levels. I like the oxyhemoglobin curve, but it does take some getting used to and some investigation. The oxyhemoglobin curve is a way to understand the affinity or natural attraction of oxygen to hemoglobin. Most oxygen in the blood is bound to hemoglobin, which is a protein found in red blood cells. The hemoglobin collects the oxygen in the lungs and releases it to the tissues. The affinity of oxygen for hemoglobin can be affected by many different factors, and we're going to discuss some of the major ones because they can affect the ease with which oxygen is picked up in the lungs and the ease with which it is released or dropped off at the tissues. On this graph, the purple curve is the normal relationship of oxygen and hemoglobin. Oxygen is picked up pretty easily and dropped off pretty easily. The green curve depicts a shift to the left, where oxygen is picked up very easily in the lungs, but it has a hard time getting dropped off at the tissues. This situation can cause hypoxia, or decreased oxygen at the tissue level, even though the blood may have adequate levels of oxygenation. The treatment for this is to increase oxygen, maximizing oxygen levels in the blood, and resolve the condition that has led to the shift to the left. Some conditions that can cause a shift to the left are hypothermia, alkalosis, and a decreased PaCO2 in arterial blood. The blue curve is known as a shift to the right. Hemoglobin has a harder time picking up oxygen in the lungs, but an easier time dropping it off at the tissues. This situation can lead to hypoxemia, or a decreased arterial oxygen level, due to the decreased affinity of oxygen for hemoglobin in the lungs. Conditions that can cause a shift to the right are acidosis, hyperthermia, and an increased PaCO2 in the blood. This chart also compares the SaO2, or the pulse ox, which is the left or vertical axis of the graph, with the PaO2, or the arterial oxygenation level, which is the lower axis of the graph. So we are comparing the pulse ox with the arterial blood gas, and this is going to show you why we can generally use a pulse ox to estimate the patient's oxygenation status. So a normal pulse ox is greater than 92% or so, and a normal PaO2 is greater than usually about 70 millimeters of mercury. The upper part of the oxyhemoglobin curve represents the pickup of the blood in the lungs. That's up here. And the lower part is the drop-off at the tissues. At the pickup point, which is the upper right-hand part of the graph, there is very little difference in the oxygen level of the blood above a PaO2 level of 60 millimeters of mercury. So even though we have, say, 70 to 100 millimeters of mercury as the normal range for the PaO2, there is very little real difference down to a PaO2 of 60% because the hemoglobin is very well saturated. Then you can see at the PaO2 of 60 or so that the pulse ox drops off quite significantly. So when we talk about ABGs and the pulse ox and the PaO2, I hope you can see how that translates into an understanding of pulse oximetry. For example, if the pulse ox reading is 65%, that would be over here, you can see that the PaO2 reading is going to be in the 40s, which is not sustainable with life. You should know the shift to the left, what that does with better pickup and worse drop-off, and the shift to the right with worse pickup and better drop-off, and the conditions that could cause each of them that are on this graph. Here's a comparison of some of the SaO2 and PaO2 levels. So you can see that in the upper levels above, well, it has here 60% because 60% is commonly accepted to be the lowest end of what's acceptable. You can compare a 95% O2 saturation might be a PaO2 of 80. But then when you get below the 60 millimeters of mercury on the PaO2 over here, then you see that these levels drop rather significantly. So hypoxemia versus hypoxia, are they the same thing? We touched briefly on these subjects in our discussion of the oxyhemoglobin curve. Pause the video and see if you can explain the difference in these two terms. Hypoxemia is a low level of oxygen in the circulating blood, a low PaO2. We would find that out by drawing an ABG. We could also assume or estimate the level of arterial oxygen by doing a pulse oximetry. Hypoxia is a failure of oxygenation at the tissue levels, so the tissues are not receiving enough oxygen in order to maintain aerobic metabolism. So both hypoxemia and hypoxia can occur at the same time, or you could just have one or the other. Generally speaking, if you have hypoxemia, you have low circulating blood oxygen, that's going to result in hypoxia. However, if you have tissue hypoxia, that does not necessarily mean that you also have hypoxemia. In the respiratory section, we are also going to cover ABGs. I know that you've had ABGs in each semester beginning with NS10 and have touched on ABGs each of the subsequent semesters. Generally speaking, normal pH is 7.35 to 7.45. The exact normal pH is right in the middle, 7.40. So sometimes texts can refer to a level being an alkalotic or an acidotic level, even though it's still in the normal range. So for example, a 7.38 might be considered an acidotic pH, even though it's a normal pH. And a 7.42 might be considered an alkalotic level, even though it's in the normal range, because it's on the alkalotic side of the exact center. Okay, so there are three methods of acid-base regulation that occur in our bodies. They're the buffer system, the respiratory system, and the renal system. You need to understand each of these levels and also know the normal pH levels. The reason it's so important to know the acid-base balances is that our body tissues need to remain in a certain balance of pH in order to sustain life. Water pH is 7, but we have to be between 7.35 and 7.45. So our body chemical reactions are influenced if we're outside of that range. As we can have vasodilation, vasoconstriction. It can affect, as you already saw in the oxyhemoglobin curve, the release of oxygen to tissues, and there are other body system reactions that are dependent on normal pH. Arterial blood gases give us a key measurement of how the ventilation and perfusion status is working in the person's body. So they tell us how the respiratory system is working, and they tell us how the metabolic system is working, if the tissues have enough oxygen to perform aerobic metabolism, or if they're performing anaerobic metabolism. So there are three ways that the body adjusts pH, as we already mentioned. The blood buffers are the fastest, and they can change the body's pH in seconds. The lungs are the second fastest. The respiratory rate is the RR. That can affect the carbon dioxide level in a matter of just minutes. And then the kidneys, they change via bicarbonate. They are the slowest adjusting system of the pH, and they can take between hours to days. And you need to know these systems, how quickly they respond. Buffers prevent body fluids from either being overly acidic or overly alkalinic. They work quickly because they're already circulating in the bloodstream. The body uses many different buffers to keep the pH in balance, but for an example, two that we're concerned with are the bicarb and carbonic acid. And this just shows you an example of how the bicarb, which is a base, can add a hydrogen ion to become a carbonic acid. And then carbonic acid then can give off a hydrogen ion and become a bicarb. So they can rapidly perform this addition or subtraction of a proton and change into a base or an acid. The respiratory system will adjust by increasing respiratory rate and depth. If we increase our respiratory rate and tidal volume, we can blow off more carbon dioxide. If we decrease our respiratory rate or tidal volume, we will increase our carbon dioxide levels. However, if the cause of the pH imbalance is the respiratory system may not be able to correct the pH balance. Bicarbonate is an anion which is a major base buffer for the acid-base balance. It's readily available in the body. Kidneys also can increase or decrease the level based on the body needs. They can do this by reabsorbing more bicarbonate or by generating bicarbonate. Here's a refresher video about how metabolic acidosis causes lactic acidosis. Know these normal ABG values, CO2 and bicarb. Thank you, and I'll see you in class.